Hi, this is Minus Joannides. This is the Optimum Academy Heart 101 series, video number 6, the electrocardiogram, the EKG, and abnormal EKG findings. So let's get started. So what can EKGs offer to us when we get requirements for an applicant for life insurance? It can offer a lot. We can be reassured of a normal sinus rhythm of the heart. We can check for heart rate. Is it fast or slow? We can check for evidence of extra premature beats, either PVCs, premature ventricular contractions, or PACs, premature atrial contractions. We can look for heart blocks, first degree, second degree, or third degree. And we can look for other kinds of blocks. We can see if there's any arrhythmias like irregular atrial fibrillation or SVT, supraventricular tachycardia. We can look for an evidence of a pacemaker that's been implanted. We can check for voltage and strain pattern of left ventricular hypertrophy, LVH, or we can look for other less common cardiac, pulmonary, or even electrolyte issues can show up on an EKG. So here's what the typical 12-lead EKG looks like, and this is what we like to get if we order an EKG as a requirement for a life insurance candidate. And you can see there should be 12 leads. I've circled leads 1, 2, and 3 in red. I've circled the augmented leads, AVR, AVL, and AVF, and aqua. And then in blue, all 6 V leads. So leads are applied across the chest in a sequence that should equal leads V1 through V6. You can notice at the top right corner, I've circled in green 10 mm per MV. That's 10 millimeters per 1 microvolt. I'm sorry, millivolt. You'll notice that there's a rectangular box standing upright. That's what 10 mm looks like. So 10 tiny boxes equals 1 millivolt, and that's what the standardization should be so that we get an accurate recording of the voltage on the 12-lead EKG. To the bottom, to the right, the left, circled in green, is 25 millimeters per second. So that's the paper speed. So we need the paper to be flowing along so that the recording can be done appropriately. So 25 millimeters per second is the normal paper speed. So I'll show you how that comes into play as well. So EKG paper standards, as I said, to the top left, 12 tiny boxes equals 1 millivolt. And then to the right of that is a typical P-wave, QRS complex, and T-wave. And that's what it should look like on standardized paper at the right paper speed and the right standardization, 10 tiny boxes per 1 millivolt. At the bottom, on the x-axis is time. So that's how many little boxes occur over a time period. So we have time on the x-axis, and then on the y-axis we have millivolts. So you can see the EKG should be standardized in this fashion, and this is what the QRS typically would look like. So I want to show you what happens if you speed up the paper speed. And if you have 50 millimeters per second in lead 2 instead of 25, which is our standard, it stretches the QRS complex out, so it looks like that the heart rate is slow, when actually it's just an incorrect paper speed. So paper speeds can affect the way that the EKG actually looks and is interpreted, so it's important to make sure that the EKG was done at the correct paper speed of 25 millimeters per second. So when you order an EKG as a requirement on an applicant, you're hoping for what's on the left, which is a normal tracing that's been done appropriately. You got all 12 leads, the standardization was correct, paper speed was correct, everything came out okay, and you are able to interpret it. But however, sometimes what you get is a disaster on the right. So you never know what you're going to get. So all kinds of problems can occur when you order an EKG, and sometimes the quality of the tracing is so bad that we have to get a repeat. However, we've become adept at being able to pick up clues, even on poorly done EKGs, to try to get some semblance of what's going on. And sometimes we're able to read it, even though the leads may be upside down, reversed, wrong standardization, or wrong paper speed. So what are some abnormal EKG terms? So you've probably heard of bradycardia, which is a slow heart rate, less than 60 beats per minute, and tachycardia is greater than 100. Atrial fibrillation is a very irregular heart rate, and we'll talk about that in a minute. And then first degree heart block is very common, and that's when the PR interval is longer than 0.24 seconds. But you may see mention of second or third degree heart blocks, and those may need more investigation if you're looking at an applicant with either of those. Left axis deviation, abbreviated LAD, also abbreviated LASH, or left anterior superior hemiblock, is often seen. And we also see complete right bundle branch block and complete left bundle branch block. And we're going to talk about those in a minute. You may see complete heart block and the person has a pacemaker installed, and so the pacemaker generates complexes, and we can see that on an EKG. Supraventricular tachycardia, SVT, or you may see PSVT, which is paroxysmal SVT, meaning it happens occasionally, suddenly, spontaneously, they go into the SVT rhythm. You may see ventricular tachycardia or fibrillation. These are much more worrisome problems, and it may be so bad that the patient and applicant has an implanted defibrillator placed, and that usually is a high risk individual. Obviously, if somebody goes into cardiac arrest, that is incompatible with life insurance policy. And you may see the term Holter monitor, which, since all of these terms I mentioned above are when an EKG is done at one point in time, what a Holter monitor provides is an EKG over a 24-hour period, or sometimes even longer, where the device is attached to the applicant or patient. They wear the Holter monitor for this extended period of time, and then all their EKG findings are recorded over that time period, and they keep a diary so that if they feel any palpitations or other sensations, they can record what happened, what time it was, and then that can be matched up with what was shown on the EKG recording. So here's some typical findings that we see. A premature atrial contraction, or PAC, is in the top, and the extra beat, which is highlighted with the little purple PAC box, it looks like a typical beat, but it just occurs early, so it's not in the usual regular sequence. So that would be a premature atrial contraction. Then in the bottom, you can see what we call a premature ventricular contraction, and that looks completely different than the other heartbeats in that tracing. So those look much different, and those are abbreviated PVC. So what happens if you have a PVC following every normal beat? So the normal beat is circled in red, the PVC is circled in green, and you'll notice that for each normal beat, it's followed by an abnormal PVC. So we call this ventricular bigeminy, and that's a little more worrisome than just having an occasional PVC. So that may require a rating for the individual who's applying, and you probably would like further investigation of what their cardiac status is. So as I mentioned earlier, first degree AV block is fairly common, and that's when the PR interval is extended. And you can see where the black arrow is pointing down. That's the P wave in the complex. And the red line measures 0.38 seconds, which is long. So we would call this a long first degree AV block. And you might want to check and see, why does this person have this? You can see in the bottom tracing to the right, here's another example of the wrong paper speed, which obviously would extend the PR interval and make it look like this is fairly significant first degree AV block. The person actually has AV block even in the correct paper speed at 25 millimeters per second, but it certainly looks a lot worse if the paper speed is faster and stretching out everything. So if you didn't know what the paper speed was, you'd be even more concerned, right? So here are some heart rhythms: fast, slow, and irregular. So at the top, sinus tachycardia, that's a fast heart rate, greater than 100. Sinus bradycardia in the middle, that's a slow heart rate, less than 60. And then you can see in atrial fibrillation at the bottom, the interval between each beat is irregular, and that's because the heart is not beating on a regular basis. So that would require rating and more investigation, what's going on to cause atrial fibrillation. So we had mentioned earlier, right and left complete bundle branch block. So here's what happens in the heart. In yellow is the electrical system of the heart, and you can see that the heart has a left bundle branch and a right bundle branch. Here, circled in white, is denoted a blockage or breaking of the left bundle. So whether you have a right bundle problem or a left bundle problem, it gives a different signature on the EKG. So it looks like what's highlighted in RBBB if you have right bundle branch block, and if you have LBBB, that's left bundle branch block. The EKG looks different, and an expert can detect which bundle is blocked by the way the EKG looks. Here's some more findings on EKGs. I'm showing the normal just as a comparison. So down at the bottom to the left is Wolff-Parkinson-White syndrome. And you can see that the arrow is pointing to a delta wave because there's a very short PR interval. In other words, the interval between the end of the P wave and the beginning of the Q, or the R wave actually, is very short, and there's what we call a delta wave. So in Wolff-Parkinson-White, you look for this delta wave. And these people can have accelerated heart rhythms because they have an accessory bundle. And sometimes they need ablation of that bundle to rid the person of this accelerated pathway. So it's called Wolff-Parkinson-White. My grandfather actually knew the doctor named White that's in this threesome. His name was Paul Dudley White, and he was a famous cardiologist, and he actually took care of one of the presidents of the United States. To the right, we have a typical finding that's often seen on paramed EKGs, and it's early repolarization where the ST segment comes off and it looks a little elevated, but this is usually just a normal variant of no consequence. However, to the bottom on the right, also a ST segment can be elevated and concave up if somebody has pericarditis, so they may have fluid around the heart or inflammation of the lining around the heart pericardium. So the ST elevation would also be up there. So you have to kind of know what the circumstances or the context was when this EKG was done. Was it just a normal routine EKG on somebody that has no heart problems, or have they had a history of pericarditis in the past? And maybe this is just another illustration that pericarditis is present. So in myocardial infarction, obviously a very severe condition that requires careful consideration if somebody applies for life insurance. There's a blockage of flow to a portion of the heart muscle due to some stenosis or problem in the coronary arteries. And to the bottom on the left, you can see what happens if there's that yellow material is blocking the flow of blood in a coronary artery, or there may be a thrombus or something blocks the flow suddenly, and we don't want any damage to the heart muscle. We need the pump to keep pumping blood around the body, so this can be a very dangerous situation. So what happens in some cases is in the EKG that I have illustrated at the right top, the red arrow points to the ST segment that is elevated when this person had a heart attack. So we call that an ST elevation myocardial infarction, and that's lead V3. That hump that the arrow is pointing to is not supposed to be there. So ST elevation myocardial infarction is called a STEMI, S-T-E-M-I. Some people have a heart attack, but they don't have that elevation of the ST segment, so we call that a non-STEMI. So at the bottom on the right, you can see the difference between somebody that has a STEMI and a non-STEMI. So that's the difference if you ever see that in a APS and an applicant for life insurance. Sometimes people can have an old MI that we pick up on an EKG, and that's when we see deep, wide Q waves in certain leads of the EKG. And in the top tracing, it's hard to tell, but there's actually a beat from lead 2 preceding that AVL. There's a beat from lead 3 preceding that AVF, and then a beat in AVF, and they all have deep, wide Q waves. So that's an old inferior MI. And in the bottom tracing, you can see there's Q waves in V2, V3, and V4. So that's an anterior myocardial infarction, and it actually has an elevated ST segment. So this person probably not only had an anterior MI, but also has a ventricular aneurysm. So you can pick up old MIs on an EKG. Also, you can find evidence that the person might have left ventricular hypertrophy or LVH, the thickening of the walls of either the septum or the left ventricular posterior wall of the heart. And to the right, to the left on the bottom is a normal EKG. I've circled that in red, what that looks like. And in the right bottom, I've circled what happens in LVH. So you have much higher voltage. You can see the arrow going up and down is much higher. And then in the tiny circle inside the bigger red circle, you can see that the ST segment is depressed and the T wave is different. And that's what we call a strain pattern. So that would be voltage with a strain pattern signifying person likely has LVH. And you've probably heard of hypertrophic cardiomyopathy, abbreviated HCM. And in this case, the person has very large voltage and also has deep T wave inversion with an ST segment lowering. And I've included the echo, which I've shown in yellow. The interventricular septum measurement in diastole is 2.1 centimeters, so that's very thick. It should be less than 1.1. And the left ventricular posterior wall in diastole is 1.4 centimeters, also thick. So this person has hypertrophic cardiomyopathy, which is a risk in families for sudden death. So obviously a very significant condition. And then lastly, ventricular fibrillation and asystole. Asystole means no beats, so it's a flat line. So in this case, the heart is just kind of flopping around and then just stops completely. So ventricular fibrillation is a life and death situation. The person needs to be shocked with a defibrillator, hopefully bring them back into a normal rhythm, and then if nothing happens, they go into asystole and die. So obviously, hopefully we never see these in an applicant for life insurance. So that completes our Heart 101 series on electrocardiograms.